Good morning and welcome to Madison Grand Rounds. This is a special day in that Peter Kleinschmidt, one of our wonderful chief residents, identified his dream speaker, and today I have the honor of introducing Dr. David Bates. Dr. Bates is a graduate of Stanford and then Johns Hopkins for his MD. He also, along the way, received a master's in public health from the Harvard School of Public Health. He took his internship and residency at OHSU in Portland, spent 1 year on the faculty, and then became a research and clinical fellow at the Brigham and Women's Hospital in Boston, where he has stayed throughout his career. He rose through the ranks from instructor, assistant, associate professor, and full professor with tenure, also holding a joint appointment in the Harvard School of Public Health. He's also served as an ongoing visiting professor at the School of Pharmacy at the University of London, as well as an honorary professor at the University of Edinburgh. He's had administrative responsibilities that fit beautifully with his clinical and research career. First, as medical director at the Brigham and Women's Hospital, he also served as chief quality officer and senior vice president, and as well as chief innovation officer and senior vice president at Brigham and Women's Hospital. He's internationally known for his research in areas including clinical decision-making and affecting physician behavior, particularly using computerized interventions, quality of care and cost effectiveness in medical practice, and outcomes assessment. I prepare before every Grand Rounds, and I wince when I come across a CV like Dr. Bates because it means about an extra half hour of synthesizing the data there. I counted 602 publications. You can do a search on JAMA and New England Journal, and there were numerous, scores. And that doesn't even include the 221 editorials, monographs, and reviews. He's been well supported extramurally throughout his career, currently with PI status with an AHRQ and a RAND Corporation grant, also receiving support from the NIH, PCORI, and other foundations. He is an excellent citizen nationally, serving on many different committees nationally and internationally, including the Institute for Healthcare Improvement, the Quality Improvement and Risk Management Committee for the Dana-Farber Institute, the International Society for Quality in Healthcare. He's a founding member of the International Academy of Health Sciences Informatics, and a number of other organizations, including the World Health Organization. On multiple occasions, he's provided testimony to the Institute of Medicine, now the National Academy, and to our own Congress, and he's an advisor to the Leapfrog Group, and has been editor of the Journal of Clinical Outcomes Management. Many, many awards, as you can imagine. Those of particular note include Master's Award from the American College of Physicians. He's an elected member of the American Society of Clinical Investigation, the Association of American Physicians, and the Institute of Medicine of the National Academies, now the National Academy of Medicine. Among his many, many lectures, including 148 international lectures, not once has he been a dream speaker before now. So with that, it's really my pleasure to introduce Dr. Bates as he presents Grand Rounds entitled, How Big Data Can Improve Clinical Care. Welcome, Dr. Bates.
Well, thanks so much. It's a great pleasure to be with you here, and thanks for that introduction. I have consulted with a number of companies. The only one of these that I will talk about today is EarlySense, and I'm only going to be presenting information that's published. So I'm going to start by giving you a little bit of backdrop, and then I'll talk about what big data are and why I think they're important. I'll talk about big data in research, which is important in an institution like this, and then I'll focus mostly on big data in clinical care and how I think big data can be used to improve care and what the key domains of improvement are. I'll also just share with you a little bit of some work that we've done recently on mobile apps. I'm going to tell you briefly about a study that we just did that involves bringing together a lot of data called the Prospect Study. Then I'm going to share with you what our institution is doing in terms of analytics. I think it's always useful to actually see what somebody else is doing in an area like this, and then I'll wrap up. So we have a big problem with the cost of healthcare in this country, and you'll note that the U.S. is at the top of this curve. Our average spending on health is really far too high, and we've got to do something about that. I think that's in some ways the most important problem we have in our healthcare system today. Now, one big change that's happened recently has been that we have adopted electronic health records. I had the privilege of serving on the Health IT Policy Committee, and we set up the meaningful use criteria. And what happened was that hospitals and providers got financial incentives for adopting electronic records. When we started out with this, it wasn't clear whether people would really buy in, whether the incentives would be enough. And as you can see, the adoption rate went up pretty quickly. There were also big concerns about whether some types of institutions would be left behind, like critical access hospitals and small urban hospitals. But basically, in this instance, the rising tide, did lift all boats, and we're now at the point at which over 90% of hospitals and over 90% of physician offices have adopted electronic health records. So there's a lot of data that's available now. Another big development has been the development of the Accountable Care Organization. That's the sort of the big idea in terms of changing the way that we pay for care. The concept of the ACO is that organizations will be accountable for quality and cost across the full continuum of care for populations. The notion is that that will result in savings against risk-adjusted projecting spending targets. Most of the savings are thought to come from care coordination and avoiding complications in the chronically ill. There are going to be strict performance criteria to try and prevent rationing. Some of you will remember the last time we did something like this, and rationing did occur. There have been penalties for excessive readmissions, which started in 2013. We've had to pay some penalties for that. And at the end of the day, the concept is that higher degrees of integration situated on top of a strong primary care base will result in savings and reduced penalties, and will result in better care. But organizations like this one and like ours have this issue. If you look at what an ideal ACO physician distribution is, you have a few subspecialists, some more specialists, a lot of primary care providers, and then lots of community and supportive services. But if you look at academic centers, many of us look like this. So that may be tricky for us. So now I'm going to talk a little bit about analytics. And the next set of stories that I tell you will relate to, come from this book, Competing on Analytics, The New Science of Winning. If you want to read one book about this topic, that's a good one to pick. How many of you have seen the film Moneyball or read the book? So lots of people. And the basic idea is that the Oakland Athletics, who are a pretty small money baseball team, did very, very well by paying attention to statistics and what what their hitters and pitchers could be expected to do, just based on statistical predictions. And they, had some really remarkable success by using this technique. And the technique is now sort of spread throughout sport. I'm happy to note that the Boston Red Sox also bought into this technique, and that led to our winning our first two World Series in 100 years. Walmart is an entity that pays a lot of attention to analytics. I'll tell you one story about them. They were trying to figure out what they should sell when a hurricane is coming. And the usual approach is you get people, you bring them into smart people, you bring them into a room and have them come up with ideas. And they thought, maybe they should, that people would want to buy water, they might want to buy flashlights. When they looked at the data, it turned out that the two leading products were strawberry Pop-Tarts and beer. So the next time a hurricane was coming, they loaded up the trucks with those items, and they did very well. And the point is, many of these things are not the kinds of things that you could work out from first principles. And how many of you are familiar with Watson? So lots of people familiar with Watson. Watson's IBM's computer that played Jeopardy, and the idea behind Watson is that it could help providers make better decisions and even suggest decisions to providers. IBM has trained Watson on oncology, and they're trying to use it to make cancer care better. I have to say that their level of success so far has been somewhat mixed, but this is an important area to watch. All right, so now let's talk a little bit about big data. Well, big data are really very large. A megabyte is a large novel. Gigabyte is the amount of information in the human genome. Terabyte is the annual world literature production. Petabyte is all the information in U.S. academic research libraries. And an exabyte is 2/3 of the annual production of information. And we're starting to have larger and larger sets of information that is available to us. And big data has been heavily hyped. Here's a cover of Nature about science in the petabyte era. And we have lots and lots of sources today. Obviously, the electronic health record is one, but genetics and genomic information is an important source. There's a tremendous amount of information from diagnostics and imaging. Increasingly, information is starting to come in from places like mobile devices and wearables, and even satellite information, video, audio, and then there's some novel sources like social media and retail. So, what are the implications of this? Well, we now have all this electronic clinical data, both inside the hospital and to a lesser extent from outside the hospital. Another thing that has happened is that natural language processing techniques have really come of age. For a long time, much of the information that we wanted to look at in the electronic health record was essentially locked away because it was in text. But now the tools to go through that and basically even map it to concepts are really pretty robust. And then we have all these other sources that we can link to. I'm going to take you through a few big data concepts. Every organization that wants to do something with big data has to establish a data warehouse, and then you typically set up what are called data marts, which are subsets of the data warehouse that are geared towards specific audiences. So you might have a cardiology data mart, you might have an oncology data mart, and so on. Data lakes are large pools of apparently unrelated data that is often helpful. An example of a data lake that you might set up would be data about the weather. Turns out the weather is predictive of many things, but you wouldn't map that to your patient level database. One important point about big data is that data don't have to be as clean as we're used to. We've spent a lot of time sort of complaining about how clean clinical data are. Many of the big data techniques are pretty tolerant of dirty data, so that is a valuable thing. Another set of terms which you ought to become familiar with are artificial intelligence, machine learning, and deep learning. Machine learning is basically a subset of artificial intelligence. People were talking about the concept of artificial intelligence for some time. And deep learning, which is now the sort of the new buzzword, is effectively it's a subset of machine learning, and it is most like the way the human brain processes. Deep learning can be supervised, it can be semi-supervised, it can be unsupervised, depending on how much direction you provide to your algorithm. One issue around big data is do you use a really simple algorithm or a complex algorithm? The simpler the algorithm is, the easier it is to explain to the people who are looking at the results how you got there. With the really complex algorithms like using a neural net or deep learning, you can't explain to people how you got there. So that sometimes for providers is kind of harder to accept. But this is something we'll all have to grapple with going forward. One thing that everybody should do when they're predicting things is to subsequently validate the results. The issue there is that anytime you develop a model to predict what's happening in a data set, it tends to reflect the idiosyncrasies of that data set. So if you then take it to a different data set, it'll perform a little less well, and it's really important to know how much less well. The companies that want to sell you these things often just want to talk about how great their model is in the first data set, and that's not really what you want to know. You want to know how it worked in a second data set. So what about big data in research? Well, I think big data is going to be absolutely critical in many areas of research. A few examples at our place include we have a pathology ePath program. We have an immunology, a big data genomic platform. And groups like this need massive sets of organized data to do their analyses. In addition, collaboration is substantially enabled by sharing large data sets, and this can help us solve some of the long-standing problems like associating phenotypes with omics and imaging, which has been hard. And this is also a really important strategy for gathering data for public health studies. At Partners, we for a long time have had this tool called the RPDR, which stands for the Research Patient Data Repository. And that's been enormously useful. It's basically a data set that includes data about everybody who's seen at Partners. And anyone who's got authorization can sit down at your desk and say, how many people were seen at Partners with congestive heart failure who got an ACE inhibitor, say, and had a high potassium level. And you can within minutes, figure out the answer to that. So it's really great for determining, for example, do you have a big enough population to do a clinical trial? If you want identified data, then you have to go through an IRB process and you can get the information. So that's been a really valuable resource. And this is being broadened to this thing that is being called the Partners Big Data Commons, which this is all work that Sean Murphy is leading. And the idea is that we'll be able to link disparate islands of patient data, both clinical and research, across Partners into this big data platform. So we're bringing in things like public health data, biobank data, there's survey data, there's imaging data, and there's also a notes repository, and all that is being linked. In addition, Sean has built this thing which they're calling a Phenotype Discovery Center. So there's RPDR sits here. There's a biobank portal here with lots of sequences. Patients are consented, so we figure out whether patients have consented to provide their DNA or their images or blood. And then there is a set of utilities that you can then do to go through and ask questions and do research. This is the kind of toolkit that I think all organizations who want to get into this area will want. But the area that I'm even more excited about is clinical data, using big data to deliver better clinical care. This is a paper that published with Ravi Parikh and Natalie Kakad on how predictive analytics could be integrated into high-value care. We coined this term the precision delivery. So the notion would be you'd be making clinical decisions based on the characteristics of the patient who's in front of you. And here's an example of that. Kaiser in Northern California was focused on curbing antibiotic use in neonates. And what they did was to use maternal health data to determine the probability of maternal onset sepsis prior to birth. They took objective clinical data from the newborn to assess sepsis probability, and then and then their obstetricians use the score to figure out whether or not to give these antibiotics to newborns. And what they showed was that about 250,000 newborns per year can be spared antibiotics using this algorithm. This is a paper that I published that was in Health Affairs a couple of years ago. And here, what we did was to try and basically come up with a list of what we thought that the 6 most important use cases were in the near term for using big data to manage care more effectively. And we argued that there were 6 use cases. First one's high-cost patients. I'll tell you a little bit about that. Second is readmissions. Third is triage decisions. The fourth is identifying patients who are decompensating. Fifth is predicting adverse events. And finally, treatment optimization, especially in patients with chronic diseases. So for high-cost patients, about 5% of patients account for half of spending. And if you get in an accountable care sort of arrangement, the very first thing you want to do is to identify this group. You do have to get data about mental health, socioeconomic status, marital, and living status. I think the secret sauce in the future will be figuring out for an individual patient what the specific actionable needs and gaps are. Our program, which I'll tell you about in a second, basically involves assigning a care coordinator to every one of these patients, and we kind of have a one-size-fits-all sort of approach to this, and everybody gets a lot of resources today. That probably will not scale going forward. So this program is called the Integrated Care Management Program, or ICMP. We use claims to identify the people who we think will be expensive. We use a tool called the LACE, which is a publicly available tool to risk stratify people using claims data from the last 12 months. We take clinical conditions from a list of about 30 and categorize those as either high, moderate, or low acuity. Combinations of conditions from each category determine the level of clinical complexity. And then in addition, hospitalizations, ER visits, and other types of utilization trigger inclusion. We are currently managing about 3,000 patients. 61% of them are women. They're elderly with a mean age of 71. 32% have a mental health diagnosis. Probably many more than that actually have a mental health diagnosis. They take an average of 17 drugs. Their PMPM is $2,000 per member per month, which is 2 to 4 times higher than average. And hospital admissions are the single most expensive thing for them, accounting for over half of costs. There's some IT infrastructure. The provider can tell that the patient's in this plan because this icon shows up. And providers get notified anytime the patient shows up in the hospital or in the ED. And we've showed that this approach has substantially reduced the number of inpatient admissions. We're in the process of scaling this. We just enrolled in a Medicaid managed care plan, and so we're now trying to do the same thing for our Medicaid population. Readmissions are also a really important area, and the Center for Medicare and Medicaid Services has strongly incentivized organizations to try and reduce their frequency. Everybody should be using an algorithm to try and predict their frequency. I think some of the key differentiators here will be tailoring the intervention to the individual patient, actually making sure that patients get the intended intervention. We have a readmission bundle, which just includes 4 things. We try to make sure that everybody gets a warm phone call from a nurse. We try and make sure that they get a clinic appointment within a week, and a couple of other things. The clinical appointment within the week has been the really hard one. And often what ends up happening is somebody makes an appointment for the patient, but the patient knows that they have no intention of coming in. And if you look to see, did they actually come in, often they didn't. And it turns out that's probably only really important in about a quarter of these patients, but we don't know who those people are today. In the future, what we should do is figure out who they are and then make really sure that it happens. Some patients probably need a particular monitoring after discharge. And you also just need to measure whether or not patients who get an intervention do or don't have a readmission. For triage, here the key thing is to figure out what the risk of complications are. This key times are admission, evaluation, transfer. And for this to work, you really need a detailed guideline that clarifies how your algorithm will inform care. So, if the algorithm says a certain thing, what do you do? A couple of examples that have been very successful, again, come from Kaiser. There's this newborns and early onset sepsis. The second one is emergency department composite scores to try and predict who will decompensate. Decompensation is another really important area, and here the issue is monitoring patients, especially outside ICUs. There are increasingly a number of tools that are becoming available that let you track patients, and I'll tell you about one in a minute. And another key here is using many parameters simultaneously, especially in ICUs. In ICUs, we have all this information. We ought to be able to bring it together. If somebody's blood pressure is going down and their urine output is going down at the same time, that's worse than if both are not occurring. EarlySense is a company that I work with from Israel. They make this device here, which sits between the mattress and the bed, and it measures the patient's pulse, the respiratory rate, and it tells you how much the patient is moving. So that is one innovation that they developed, probably the most important one. But they also have set things up so that the data from this is processed centrally, and they use some big data approaches to try and figure out which signals are truly important. And then the third thing that they do is the system is interfaced to the nurse's handheld device. And we've really underutilized our handheld devices in medical care. Everybody is using their handheld device all the time, but think about how often it's for something that relates to the medical care that you're delivering. It's probably not very frequent. So what they did is, if the patient is doing poorly, the nurse gets a message, says, go take a look at this patient. Their pulse has just gone up, and they can then act. And we studied this in a hospital in the Los Angeles area. Studied 7,643 patients. This was medical and surgical units, and what we found was that the length of stay fell 9% on the unit, which is nice. But what was really important was that the amount of time that patients spent in the ICU was 45% less. So again, if you find people early, you can keep them from doing really badly. And in addition, they were 86% less likely to code. A couple of other points about this. This device had only 2.2 alerts for every 100 recording hours, and 50% resulted in nurse action. That's dramatically different than most of the monitoring approaches that we use, like pulse ox, telemetry, and cardiovascular monitors, which have this enormous rate of alerts, between 160 and 730 alerts for every 100 hours, and a very low proportion result in action. We did an economic analysis of this monitor and found that break-even was within a half a year, and the 5-year return on investment was $9.1 million. Even with conservative assumptions, it was $3.3 million and 0.75 years. Adverse events are another important target. So here, some of the ones that I think are the most important are renal failure. Changes in renal function are often apparent before the patient truly has a major negative event. Infection, using combinations of vital signs and related parameters to identify the patient who's infected. One example is heart rate variability in very low birth weight infants. Heart rate variability is not something that I ever thought about clinically, but it turns out things like that can be quite predictive. And then finally, adverse drug events, which patients may experience them using both genetic and genomic and clinical information. Diseases affecting multiple organ systems are also really important, especially in medicine. Chronic conditions are extremely costly. If we could predict people's trajectory, that could enable caregivers to target complex and expensive therapies to the patients who would benefit the most. This is especially true in autoimmune conditions. And registries here, like PCORNet, can also be leveraged because they have longitudinal data about how people with chronic conditions are doing. Now, there are a number of new sources of information. One of the ones that I'm especially excited about is mobile apps. So, on this axis is time, and this is the level of maturity of app development. People have started to recognize that apps are important. There are issues around security and privacy and so on. I'm hopeful that we'll eventually get out to here where people are prescribing these routinely. How many of you have ever prescribed an app to a patient? So just a couple of people raised their hand. I think before too long it will be everybody here. But apps, as they are today, have some limitations. Here's a story about one particular app called GingerIL. They use big data techniques to try and improve mental health. The way this works is it collects data from your smartphone about how you're using texting, your phone, and where you are, and they try to use that to predict how you're feeling. And it turns out, you obviously have to get consent from people to do this, but they can tell with a very high degree of certainty how you're doing, and development with depression is very closely correlated with patterns of use. If you do this, this could enable us to intervene earlier. Next, I'm going to tell you about this study that we just did recently called the Prospect Study. This is the study that we finished recently that I'm the most excited about. Our goal was to try and transform the intensive care and oncology environments through implementation of a patient-centered intervention, and there was a focus both on patients and care partners. Say a word about care partners. We haven't invested enough in care partners in health. It turns out that not everybody has a healthcare proxy, but almost all of you could identify somebody who would help you out if you say needed to get home after a colonoscopy or a surgical procedure, and that's what we mean by care partners. So the intervention in this study was twofold. The first was to implement something called the patient satisfactive model. What that is basically an approach in which we train both doctors and nurses to ask patients what they expect. Both doctors and nurses say that they believe that they should ask patients what to expect, but then if you ask them, do you really ask patients what they're expecting on a routine basis, we basically don't get around to that very often. The second part of the intervention was a web-based patient-centered toolkit. And here what we did was basically to ask patients and families what information they wanted when they're in the hospital, and then we put that together. And the intervention included both provider-facing tools and a set of patient-facing tools. So here's the tool that we gave to patients. We basically handed them an iPad, and I'll show you that in more detail. We did have to get patient or healthcare proxy consent to do this. And here's what the screen looks like. People said that they wanted to know who was on their care team. They wanted to be able to send and receive messages. We wanted to try and figure out what patients' goals were and what the care team's goals were, and to see whether or not we were meeting the care team goals. Patients also wanted to see information about their tests, their drugs, discharge information, and so on. Another thing that we built was a patient safety checklist and then a dashboard. And this is the ICU dashboard. We built this outside Epic, but it appears in Epic, and people feel like they're in Epic when they're using it. And so you can look here and just see, which patients to focus on. Here there's a red. Here there's another red. So this has been very positively received by teams. And here's the patient-level dashboard. So you can click on the patient. Patient here is Hermione Granger. Hermione has a urinary tract infection, and the issue is that the Foley's been in too long. And you can just very rapidly see, what's the problem and how to manage it. One of the things that I think we're all struggling with is we have all these checklists that we're trying to manage, and it's pretty hard for the clinical team to kind of keep on top of this. So what do we find? Well, this is published in Critical Care in 2017. We found that the harm rate fell by about a third. The satisfaction rate amongst patients went up a remarkable amount. This is by far the biggest increase in satisfaction that we've ever seen with any intervention. So it went up from 72% to 93%. Care partners were also more satisfied. We did a little better in terms of concordance, in terms of goals. Still not that great. And disappointingly, resource utilization did not change. All right. So now I'm going to switch gears and tell you a little bit about what we're actually doing with this. We've had a long culture for quite a while of trying to use data for decision making, and we've had this tool that when we put it in was state of the art called the Balanced Scorecard. We have data that come from our physician organization and other places. We have some two-dimensional reporting and canned reports on what happened. There's a little bit of interactive analysis capability, but frankly, not too much. Where we want to go is we want to be able to do predictive modeling and leverage both internal and external environmental data to try and predict the future. We want to have appropriate staffing levels given what we expect the future state will be. We want to try and predict our margin rates. And then we want to be able to do some complex statistical analyses to look at practice patterns and variations. Here are some sample projects that we're taking on. One involves the obstetric inpatient census and trying to predict how full the institution will be. Another focuses on targeting high-risk interventions. I talked about that some. Doing better with patient decompensation, managing some of our chronic patients. Looking at provider care variation, that turns out to be really valuable. Looking to see how we're doing with bundled payments. And then we're going to basically scrap the balanced scorecard and put in place a new set of analytic tools. Here's a specific example around the obstetric census. And the issue here is that we basically lost a contract for a large chunk of our obstetric patients. We ended up in a situation where we had too many obstetric nurses, but it's very hard to staff appropriately. You can see here we're basically quite a bit overstaffed for some time. We estimated that if we'd had analytics tools to try and predict what we actually needed to do in terms of staffing, we could have saved $230,000 a year just on one unit. If you're going to do this, you need a few sets of tools. You need some analytics tools. You need registries, which are basically lists of patients with certain conditions so you can figure out how you're doing. You need monitoring devices, and they need to be linked. And then you need a data warehouse with MARTs. And we've set up something that we're calling the Enterprise Data Warehouse. Our implementation has been focused on time to value and pressing business priorities. We tried to avoid just building this big database in the sky and having to wait too long to get something from it. And there are three areas we're focusing on. Healthcare directions, so drivers of hospital volume and margins, episodes of care, looking at variation in longitudinal episodic experience of patients across the inpatient and outpatient setting, and then trying to identify some population insights. So looking at medical expenses and utilization driving trends in populations. We partnered with a company called Health Catalyst. They have both an adaptive methodology and a lot of healthcare expertise. They were founded in 2008, and they are based in Salt Lake City. They work with a number of hospital systems. And besides being an implementation partner, our institution is elected to invest in them, and we're currently co-developing analytic content. We hope that that will help them work on things that will be more useful to us. We have used Clarity as which is we're also an Epic shop. We used Epic's Clarity reporting database, and that's a really important source for our enterprise data warehouse. But there are many other types of data that are in the data warehouse, and Clarity was very clearly not sufficient for managing all our reporting needs. First of all, it just had Epic data. It didn't have data about claims or PeopleSoft data or cost accounting data or other sources. And we did a national look at how people were choosing to manage this, and nearly everybody had data warehouses that were not just using Epic to integrate these very data sets. You also need a set of tools so that people can ask questions of the data. And we have things set up in several ways. So one approach is some people are pretty sophisticated and they can go into EDW and basically bring their own tools and ask questions. But we also have an application called ClickView that is for people who are a little less sophisticated. And then there's also an approach where there's a managed gateway. There's a tool called Business Objects that lets you ask questions directly of Clarity. Another paper that I just want to point you to is this paper that I published with Catherine Cresswell and Aziz Sheikh in the New England Journal Catalyst. And we argued in this paper that every organization needs a data science strategy, that they should be thinking about what their data warehouse is, who the people are who are going to work on data science, and how those data needs will be met. When I go around the country, most organizations really do not have a robust data science strategy, and that will be pivotal going forward. If you look across our institution at what are we doing to make care better, we're doing lots of different things. So we have some things that are focused on the population side, some things that are focused on the episodic side, and a lot of things that cross over. On the population front, our biggest interventions are we're taking all our primary care practices and converting them to medical homes. We also have the high-risk program that I talked about. In the inpatient setting, we have a couple of things that are important. Perhaps the most important is this approach which we call patient progression. And there, what we've done is to assign for every unit in our hospital, we identify one physician who's responsible for that unit, and we pair them with a nurse who's responsible for the unit, and they meet on a regular basis and talk about how the unit's doing and figure out how things could be done better. What we found before we did this is that nobody really felt ownership over most units. And then we have a lot of things that kind of are in the middle here. One program that I'll call out is the SCAMPS program. That stands for Standardized Clinical Assessment and Management Plans. And this is an approach that we use to basically work on specific conditions and get providers engaged to try and improve care for an individual condition. These are different than guidelines because basically what we do is we collect data for a specific condition and then try to use the data to figure out what we should do going forward. One thing that's on the near horizon is the Internet of Things. And what's happening is increasingly the objects that are in our lives are starting to collect data. Your refrigerator will soon be collecting data if it doesn't already. Your car very likely will be collecting a lot of data. And all these things are going to be linked. So we have lots of connected people. There are more and more apps that are being used. There are all these embedded in intelligent systems. And this is going to result in just massive quantities of data overall. One of the areas that I'm particularly that's particularly important to me is the area of safety. In terms of safety, some of the things that I think will be near-term wins are predicting decompensation, building better tools to enable us to visualize who is doing well, who's not doing well, predicting trajectories for patients, predicting specific types of adverse events, and then doing a better job with pharmacovigilance. I think that data and analytics are going to be foundational in every clinical redesign effort. If we can do this well, we'll be able to do a lot more than we can today. If I look at where we are in our own institution, we already have a moderately good picture of care in the hospital with a balanced scorecard, but we basically know almost nothing about what's going on outside the hospital. And that's, in these accountable care arrangements, that's 70% of our costs. So we just absolutely have to learn more about that. We're planning to make a substantial investment in this area. If you go back to the big picture and look at how organizations behave under fee-for-service versus an integrated care, things are really pretty different. With fee-for-service, you're incented by volume. In the future, we'll be incented by value. We historically have focused on acute illness and high-margin services. In the future, we'll be focusing much more on prevention and care coordination. Our focus has very much been on the individual patient. We have to move to focusing on the population. Still, in our leadership team, we have a lot of conversations about filling beds. Filling beds is not a good thing. If you are under one of these accountable care organizations, what you want to do is prevent unnecessary admissions and readmissions. We do have a really cool program that has been implemented. It's a home hospital program in which we take people who are low risk and have them go home and manage them. And we've showed that has reduced the cost of care by about half, and the outcomes are actually better. Patients are far more active when we manage them using that approach, and we're trying to scale that right now. Here, the payer has more risk. Under integrated care, we're going to have more risk, so that will be a different way of looking at things. And throughout this, health IT is going to be key. For ACOs, there are a number of questions. One is, how much integration do you need to be competitive? We typically have not had very strong relationships, for example, with post-acute facilities. We had one very strong relationship with a long-term care center, and then it was condemned. So that was kind of a big blow to us, and we're trying to work out what to do. You have to work out what degree of cultural transformation you need and how much stakeholder alignment you need. For academic centers, a key question is, how are the changes in reimbursement going to affect the tripartite mission? In particular, we've paid for education and research typically from clinical care, and that may not be possible going forward. One really centrally important one and thorny one in a place like this is, if you have shared savings, how are they going to be distributed? Do they all go to the subspecialists like they have in the past? That probably is not the right answer. And then finally, how do you weather the transition zone between fee-for-service and the accountable care organization, because the incentives are not aligned? So to wrap up, clinical data are now nearly ubiquitous in the U.S. The levels of adoption are actually now over 90%. And yet most organizations have not figured out how best to leverage these data. Every organization, I think, needs to invest. Every organization needs a data strategy. I think these big data approaches are going to result in many insights, both in clinical care and research. I've shared with you a few of the examples that I think are most likely to bear fruit early on. If you look at what will help us make better predictions and make better choices in terms of clinical care, I think some of the novel sources are going to provide the most improvement. For example, data from social media or mobile applications. And at the end of the day, I think this is a really big deal. I think this could be as transformative as the internet. I can still remember when a colleague of mine, John Teich, who some people in the audience know, came in and said to me, there's this thing called the internet. Do you think it'll be important? Will we ever, for example, put our health records on the internet? And And we weren't sure about that. That was not that long ago. This is going to be especially true as we move to the Internet of Things. This is going to have many privacy implications. I think true privacy may no longer be possible. We've got to get better safeguards in place than we have today. For me, the killer app has been Google Maps. You guys have a lot of snow here. We had a winter about 3 years ago now in which we just got a ton of snow. And the usual ways that I would go to the hospital basically no longer worked much of the time. So, what I would do is, every morning, fire up Google Maps and figure out which way to go. It was saving me, 35 or 40 minutes a day, and I went 30. I've been living in the same place for 30 years. I went 30 new ways to work. I never could have figured that out on my own. So there will be things like that come to healthcare. And I think the future will involve linking many of the technologies that I've talked about, social media, mobile data, using big data approaches, and also the cloud, as well as sensing technologies through the Internet of Things. So I will stop there and take a few questions.
Thank you, Dr. Bates. I'll ask you to call on the audience and please repeat the question for the recording.
Sure. Joel.
You mentioned the prospect trial and some striking benefits of prospect. There are some similarities between that and Epic's MyChart technology. UW Health is starting to implement inpatient MyChart as opposed to the widely known other outpatient MyChart. Do you have any sense, it's not been as widely studied, do you have some sense of the comparability of these two?
Yeah, the application that we studied is better than MyChart Bedside, which is the inpatient. So the question is, what's the how similar are the application that I talked about in the prospect study and MyChart Bedside, and the application that we developed is significantly sort of further along, and it's much more patient-centered. We are planning to implement MyChart Bedside and then take some chunks from what we developed and basically plug it in, and it'll be possible to do that. The MyChart Bedside has not been that well received at places that have implemented it so far. And I don't know exactly what the specific issues with that are. I think it'll be possible, though, to work them out over time. Yeah. No, so that's a great question, and the question is basically some evidence that electronic health records today are associated with burnout. There's all these data; they're being presented to us in unorganized ways. I think our what we absolutely have to do is actually make things simpler for people, and not push too much data on them. Come to people in much more selective ways. One example that I think is a good one is the EarlySense approach, where you get a message, very infrequently. It's very simple. It's reasonably directive. And I absolutely agree with you that we've got to solve this issue, that we're not in a good place right now. Yeah.
So you mentioned on the potential challenge with the ACO model, the potential to jeopardize education and research. Is it the right question, or would the right question be, how can we adjust education and research to the new model?
So the question is, should we adjust education and research to the new model versus? I think every organization is going to have to figure out how it pays for things, and increasingly we're moving to an approach in which everything really does have to pay for itself, so that every tub will have to be on its own bottom. We want to, I think, eventually move to approaches where what you get for your research grant actually pays for the research that you do. That in terms of education, we're not subsidizing it from a number of other places. That will be hard, but I do think it's doable over time. We've had all sorts of implicit subsidies in healthcare for a long time. Yeah.
That's a wonderful talk. You had at the base of your pyramid community services, and as we move to being accountable and understand the social determinants of health, our healthcare institutions poised to provide community educators, housing, community psych, community representatives in their organizations to really change the things that are determining that 5% of individuals of the right cause.
Yeah, so that's a great question. The question is, are organizations really set up to work with communities and enable delivery of community services? And I would say we are not today, and that's something that we're going to have to get better at. If you go to other countries, they do a much better job of this than we do. Most of the European countries are really quite a bit better, and that's, I think, one of the sort of the most important sort of fundamental areas of transformation that we will need to deal with. We don't even have a good sense of sort of what the community resources are and how, for a given individual, we take someone and plug them into those, and so this is one of the places where I think the most work needs to be done going forward. There's some exciting innovations in this area. Geisinger, for example, has this program where they've showed that they invest in growing fresh food for some specific populations, including their diabetic population, and that has been highly cost effective for them to use that sort of approach. Yeah.
I have a question about predictive modeling. So in primary care here at UW, we have complex care managers, primary care coordinators, about 270,000 home patients. We just started to predictive model how we're going to use our complex care coordinators in a different way. In our ACO population, we have about 4,000 of them. And what's fascinating, we just got the data, and it is not going to pass this year test with our clinicians. Our primary care docs are looking at that data, and they're saying, wow, those are not my most labor-intensive patients. Those are not my sickest patients. Those are not the patients that are burning me out. And yet, I think they're going to be the patients that, in this predictive model, will save the organization money. What are your thoughts on that?
Well, so that's a great point, and we found the same thing. So here the question is, if you do the predictive model in primary care and look at who the patients are, then show them to the clinicians. They don't feel like they're the right set of people. We actually do take our lists and we show them to the clinicians, and we give them the opportunity to say, this person doesn't need help, this person doesn't need help, and what we have not been able to do is to say you can then add all these other people, because we don't have enough resources to do that. But we do allow some addition, but some back and forth around that is the best way to proceed.
We're going to have to close there. I want to thank Dr. Bates, present him a plaque signed by our chief residents. Thank you so much.
Thank you. Great.